All right, so this patient has a hepatopulmonary syndrome, and in this case, it's caused by hepatitis C cirrhosis. The pathophysiology of a hepatopulmonary syndrome occurs when a patient has cirrhosis and consequent pulmonary hypertension that leads to the decreased breakdown of some of our vasoactive substances like nitric oxide. Nitric oxide makes its way to the lungs, which causes pulmonary vascular dilation, especially in the lung bases. So when this happens, right, if we think about Fick's law of diffusion, you don't have to memorize this equation, but we know that the rate of diffusion is inversely proportional to the thickness of my membrane. So my membrane now that the red blood cells are pushing through and in contact with the alveoli are thicker, they're wider, right, because they're dilated. The blood is also able to move faster, right? So it's going to be really hard for these patients to drive oxygen onto their hemoglobin molecules because they're moving faster and the membrane is thicker. So this gets exacerbated when the patient is sitting upright or standing, because when they're sitting upright or standing, the gravity pulls blood to the lower lung bases. So that's why these patients feel more dyspneic when they're sitting up or standing. That's called platypnea. And they get a drop in their SaO2 or PaO2 when they're sitting or standing. That's called orthodexia. So you may also see this referred to as platypnea orthodexia syndrome. So these patients feel worse sitting or standing up, and they feel better lying down for that exact reason. We also saw in this case that the patient had an intracardiac bubble study done. And what we saw is when we injected the bubbles into a venous system, right, they move their way back, they make their way to the right atrium. And if this was an intracardiac problem, like let's say a PFO, which is common, it's in roughly occurs in about 25% of all patients. If that is occurring, we would see the bubbles go from the right atrium to the left atrium now, like really rapidly. If you reread my question, the bubbles did occur in the left atrium. We did see them show up, but it took a while. So normally in a normal physiological state, the bubbles should not move from the right atrium to the left atrium. That's because my pulmonary capillaries are really small and the bubbles get stuck and they get broken down. However, in hepatopulmonary syndrome, because the vessels are larger now, the bubbles are able to move through, but the bubbles still have to go from the right side of the heart through the lungs to the left. Whereas in a PFO, secondary to Eisenmenger syndrome, where my shunt switches from a left to right to a right to left, those bubbles are going to show up into the right atrium immediately, okay? Because we've got the direct connection between the sides of the heart. So what I wanted to do now was just kind of quickly go through the wrong answers. So if you saw, the first answer was impaired ventilation due to due to diaphragmatic excursion via the ascites. So basically the ascites is pushing down on my diaphragm. That would lead to restrictive lung disease. It would cause exertional dyspnea and not really positional dyspnea. We also would probably see some sort of abnormality on the chest x-ray, and surely we would see some sort of abnormality on the PFTs. Remember, restrictive lung disease, we see the FEV1 divided by FVC is either equal to or greater than 0.7, and the FVC is usually pretty low in those patients, okay? But we saw that the PFTs in the chest x-ray were normal. When we think about exudative pleural effusion, that doesn't make sense in a patient with cirrhosis, right? The three major causes of transidative effusion are going to be due to things like cirrhosis, congestive heart failure, nephrotic syndrome, and I'd even add protein-losing enteropathy in there. So remember, transidative effusions are due to increased hydrostatic pressure, decreased oncotic pressure, okay? Transidative effusion compared to exudative effusion, where exudative effusion is usually due to vascular permeability in the settings of like pneumonias, cancer, and pulmonary embolism. And so how we can define these is we can do a thoracentesis, we can pull the fluid off, and we can use Light's criteria. Light's criteria states we need 1 out of the 3. We need the protein in the pleural space to be greater than 0.5 times the protein in my serum. We need the LDH in my pleural space to be greater than 0.6 times the level in my serum, or we need the LDH in my pleural space to be greater than 2/3 of the highest level of my normal LDH in my serum. So let's say the LDH ratio is like the high end of normal on my lab value is 300. We would need that LDH in my serum or in my pleural to be greater than 2/3 of 300, right? I just need one of those three. This patient has cirrhosis. Cirrhosis usually leads to a transidative pleural effusion due to a decrease in oncotic pressure due to a lack of albumin. So this is not going to be causing an exudative effusion. We don't see a pneumonia, TB. We don't see malignancy. We don't see pulmonary embolism. We already talked about the intracardiac shunt. We would have seen the bubbles move over right away. We saw delayed bubbles. So hopefully that helps you key in on hepatopulmonary syndrome and platypnea orthodexia.